Okay, so I think we're now going to begin our session. My name's Andrew Jack from the Financial Times. I'm also a director of FIND, and it's a great pleasure to help host and moderate this discussion over the next hour or so on assessing the use of digital tools to strengthen COVID-19 management. We're very keen to learn about particularly the experience of Kenya, but also insights from other countries. So thank you all those, not only our panelists here, but also all of you who are attending. We're going to have about half an hour of initial reflections and presentations, particularly learning about Kenya's experience, and then open it up for 30 minutes of your reactions and questions. So do please already start to use the Q&A function here to post your thoughts, and I'll try to get through as many of those as I can. But we know how fundamentally important digital technology is becoming, how important it is potentially to help with diagnosis of disease in general, and of course how it's come to the fore, particularly during COVID, but raising all sorts of questions about its efficacy and validity, and thinking about how it gets integrated into existing systems, how it can be decentralized to point of care, what its potential really could be, but also understand a bit about some of the pitfalls and challenges that need to be overcome as we try to identify these issues for policymakers and health practitioners around the world. So on our panel, we have Jane Aduda, who's from the Digital Health Applied Research Center at Jomo Kenyatta University of Agriculture and Technology, Onesmus Kamau, head of the Division of Health Informatics and Digital Health at the Kenyan Ministry of Health, and Rigveda Kadam, head of Digital Access at FIND. So with great pleasure, let me first of all hand over to you, Jane, for your initial insights and reflections, please, on this really important issue.
Thank you very much, Andrew Jack, and thank you everybody who's attending this particular webinar. Yes, so I think if we look at the global, and I'm trying to minimize my pain so that it doesn't interfere. Great. Yeah, so if we look at the whole issue about COVID, first of all, the use of digital tools actually in health, it's actually very key because we can use digital tools for surveillance, to actually be able to collect and monitor real-time epidemiological data, identify hotspots, and support contact tracing. They're also very useful for prevention and actually through sensitization, education, community outreach, also for diagnosis, in terms of assessing symptoms, tracking testing numbers and outcomes, and even for delivery of care, where you can provide clinical guidance to health workers, provide patient services, including referrals, monitoring, and other information. So basically, digital tools actually can enhance case management and strengthen pandemic response in several ways. We can, for example, actually conduct risk screening. We can track tests. We can transmit outcomes real time and also support rapid clinical decision making across the care cascade. Digital tools are also useful because they can actually help us to capture and analyze real-time data, comprehensive data on patients, providers, and process and products. Just give me a minute, sorry. And then they can also, through digital tools, we can also be able to accelerate exchange of information between different levels of the health system. And actually, this would then improve surveillance and decision making. Next slide, please. Thank you. So this is now for the Kenyan case. So this is, so we carried out a study at the Digital Health Applied Research Center. We carried out a study, of course, in partnership with the Ministry of Health, and this was supported by FIND. And in this particular study, we wanted to assess the utilization of COVID-19 or of digital tools in the management of COVID-19 in Kenya. So basically, this study was carried out in the year 2020, and this is actually was at the height of COVID in the country. And the first one of the objective of this study was actually to map the. Sorry, I think maybe I can just go back to the previous slide. Thank you. So yeah, so what we did in this study is we actually mapped some of the tools that were used in the management of COVID, and then we also monitored the utilization of various tools that were used at the time when we were handling this. Next slide, please. Thank you. So this assessment actually mapped the uptake of digital tools that were deployed and we only considered 2 counties. We looked at Machakos County, which is actually considered sort of a residential county for the people who work in Nairobi, and then also Mombasa, which is actually a tourist county and so has a lot of movement and activity. And we looked at how we mapped the use of digital tools in these 2 counties in terms of supporting COVID-19 screening, testing, contact tracing, and patient management. Then after this, of course, we documented, we did a technical report on we documented the technical and operational challenges that were experienced, with the use of these tools. Then, of course, we also looked at the data that were captured by these tools. So we analyzed the quantitative data on the COVID-19 management cascade that were captured in the digital tools, and we used this as an opportunity to try identify areas of strengthening pandemic response. And the findings and recommendations were documented in a policy brief and a report. And the next couple of slides are actually going to look at some of the recommendations that we made from this study. Next slide. Thank you. So on the onset of COVID, I think the ministry, together with other partners, came together and designed this surveillance system for COVID-19. So several tools, of course, supported by several partners, were actually brought into play, and this is the cascade that was designed. The first opportunity was to be able to identify cases and notify the health workers. So alerts would be sent, and once this had been once the cases had been notified, then we would have to do case investigation. So that would actually, so if alerts were sent, community health workers, it was envisaged if an alert was sent, community health workers would be sent to those specific locations to try and do case investigation. Of course, some of the cases were also identified maybe in health facilities, and so therefore, again, at that point, case investigation happened. And there are certain tools that were used for this particular point of case investigation. We had tools like the COVID-19 tracker, which is of course powered by the CHT toolkit. We had the Kenya EMR that was used. We had the lab management information system, and we also had, of course, counties being innovative, because at some point, not all these tools were deployed simultaneously, and so counties also were very innovative, and they also came up with Excel-based tools just to try and be able to get this information. So after case investigation, of course, these cases, there was some form of screening, all right, and then they were sent to the labs, and then this was captured in the lab management systems. And then based on the outcome, if of course if they were found to be positive of COVID-19, they were sent to isolation, and then of course they had to be contact tracing and contact management. Again, there were digital tools that were designed to do this, like the COVID tracker app had that functionality, the Kenya EMR had that functionality, but then there was also the JKUAT app, which was also developed to actually manage self-registration and contact management. And then there was also, of course, quarantine, and of course, in the beginning, we had people quarantined in institutions and health facilities, and again, the same tools were used to monitor them in quarantine. Eventually, when we got to community transmission, it was not possible, it was not plausible to have these things, the people under institutional quarantine, and so they were sent to home-based care. And again, JKUAT app had a module for home-based care, so that they were able to monitor these the COVID cases. And then also all these tools were designed to actually be able to communicate with each other. So there was a platform for interoperability, and they all had all these functionalities. So this is what was designed. Next slide. Thank you. So after this, so when we carried out the study, of course, we realized that we had a very good framework in terms of how these tools were supposed to operate and how they're supposed to share information. And we actually, some of the key successes we identified from this study was that we had a majority of facilities that were routinely reporting data to MOH through the National Electronic Lab System. And this was made possible, whether the health facilities were using the tools that were designed by the ministry, or whether they actually had designed their own Excel-based sheets. The lab management system provided an opportunity for everybody to be able to upload data on the national platform. And of course, this then really enhanced the use of digital tools, especially at the testing level. One of the key areas of success of use of digital tools was in the labs. It was almost 98%. All the cases that were were identified and sent to the labs were all captured on a digital tool, and that for us was something that was very, very strong. In addition, we had this JKUAT app that had, it was a local solution that had very good functionalities. It could capture data end to end. It had opportunity of capturing data from screening or through testing, to contact tracing and up to case management. And of course, from this, of course, so Jitenge is actually derived from a Swahili word, which means self-testing. So basically that is actually what, self-isolation, sorry. So that's actually what Jitenge means. Jitenge is a Swahili word that means self-isolate. So it was a module that was used for self-reporting and self-isolation. And from this, we actually would recommend, because these tools existed and they had these functionalities, we recommended stronger integration and collaboration to reduce the level of fragmentation, because all these tools had all these functionalities, but they all more or less operated in a siloed sense, so that they were not really communicating very well. So despite having these very good functionalities, they were not able to transmit this information to the other systems that would have actually given us a lot of value. So there's need, we recommend that there's also need for systematic documentation of screening data, because screening was a very key component, but most of the data that was obtained from the screening process was not really documented, and so therefore it ended up not being, not adding value to the whole process. So we also saw a need to strengthen contact tracing, of course, taking into account some socioeconomic barriers that are experienced. Next slide. So this is just a snippet of what we found, and this was only possible because we were able to access some of the data that was captured in digital tools. So of course, we noticed wide variations in terms of the level of utilization of tools across counties and across facilities. Even in the two counties where we went to, that's Mombasa and Machakos, there was a lot of variation. And this sometimes was a function of the specific partner who was supporting maybe a specific tool that was deployed. So there were differences between the national and county data captured in the digital systems, and this actually shows actually the need for a lot of collaborative efforts to try and have all these things operating in a seamless framework. So if you can look at maybe the first panel there, this is the entire cascade from testing. Of course, screening would have been a key component, but we were not able to capture. Screening data was not captured. So for the testing bit, we are actually having two colors. I think one is a deep form of blue and one is a lighter form of blue. So we have the national tool versus tools used at the county. And at the national, of course, we can see that for Mombasa County, if you're looking at the proportion of cases with specimens tested within 72 hours, of all the cases that were reported on the tool, the national tool for Mombasa County, 77% of them were actually tested within 72 hours. For Machakos, we had 67%. But if you look at the specific county-based tools, because Mombasa also had their own solutions, Machakos also had their own solutions. On this particular case, Machakos County did very well because all the data that they captured, you know, almost everything was tested within 72 hours. In Mombasa County, again, that we had a showing of only 35%. Then we had the next bit of, we also looked at the turnaround time between specimen collection and return of results. And here you can see, again, the national tool is showing us a longer turnaround time for both counties, 4.87 days for Mombasa, 6.29 days for Machakos, as opposed to the county-specific tools that were just 1.5 days, 1 day for Mombasa County, and maybe 3.8 days for Mombasa. And sorry, 1 day for Mombasa, sorry, and 3.8 for Machakos. And I think this was also occasioned by the fact that the national. So when you look at the national figures, the figures are being captured based on county of residence. So you'd find that even if, for example, a case was actually found in maybe a different county, like maybe Nakuru, but this person's county of residence is Mombasa, then this would actually be keyed in as a case for Mombasa. And because of that, therefore, we saw some of these disparities. In addition to that, of course, some testing was being done by private laboratories, and these private labs were not following, some of them were not following the county reporting channels. So therefore, you'd find like, for example, a lab like Aga Khan in Mombasa, when they do their testing, they send their samples to the Aga Khan lab in Nairobi, and then the testing is done in Aga Khan lab in Nairobi, and then these results go back to the county. So that was actually the reason why we saw the national tool having longer turnaround times as opposed to the county-specific tools. And then, of course, the last pane is also looking at the proportion of registered contacts that were screened. Again, here the national tool was doing a lot better than the county-specific tools, naturally because at national level, there was a much better mechanism of contact tracing as opposed to what was happening at county level. So again, you can see the showing. Of course, Machakos had a very good way of contact tracing. They were actually able to trace more contacts than Mombasa County. Next slide. So from this study, we came up with a couple of recommendations, and the first recommendation was around the level of interoperability. So we recommended a stronger integration and collaboration to reduce the level of fragmentation and discrepancies in data that we saw in the tools, because this then, of course, reduces, to some degree, the value that this particular data can actually give. So the main challenges, of course, that occasioned this was limited alignment and exchange of information between the various tools. They had all these functionalities, they had opportunity to exchange of communication, but that wasn't actually coming through very well. There was also one of the things we found that was very, very tasking was the lack of a unique identifier. So you'd find that even following cases in the particular systems became difficult because we didn't have a unique ID running through the entire process. And this, of course, caused discrepancies in data that was obtained from the digital platforms. And so we had to clean a lot of this data, and some of them were not probably analyzable because of not having a unique identifier. There were also challenges with capturing complete end-to-end patient data across a continuum of care, because there were tools that were designated for every specific stage in the continuum of care. But if they were not communicating, then there was that break. So recommendation here should be that there should be collaborative efforts between, of course, the Ministry of Health and partners to align digital solutions with the Kenya Health Information Systems Interoperability Framework, so that these tools are able to actually, communicate freely. And of course, this would then lead to to do this. I think one of the things that we need is develop a minimum set of standards for all digital solutions, including the open access solutions, so that interoperability actually, is achieved. And this interoperability would then optimize the quality and consistency of data capture. The other thing is, of course, also to look at the issue of the unique identifier, scaling the unique identifier system that is currently being piloted to see that if it can be used across all health systems. This then, of course, adds quality to the level of data access across the continuum of care. Next slide, please. The second recommendation is to systematically document the screening data so that we ensure linkage to care for suspect cases. Again, we saw that there was screening. Screening was a very key component in the management, and still is a very key component in the management of COVID-19. And screening was done. Screening is still being done at most levels, but we realized that this data was not being captured. So the screening practices were largely, served as, access control, to congregate settings, but they were not really used, in terms of managing high-risk individuals or identifying high-risk individuals for testing. And then for most cases being tested, digital systems did not capture the screening outcomes. And of course, that it was a very key component. And so we recommended increased use of digital tools to conduct screening, to capture data on risk factors in the patient population, so that you can support linkage to care. This, of course, would have had the value of giving a deeper understanding of risk factors, and this can inform surveillance and clinical management. And also COVID-19 screening data can also inform targeted testing of other diseases with overlapping symptoms, especially respiratory diseases. And an opportunity that we are carrying out right now, the DHARC, this particular center, again, in partnership with Ministry of Health, again, of course, being supported by FIND, is we are implementing a study we are calling the border study. Border is a term used to refer to motorcycle riders, motorcycle taxi riders. So to try and implement some of the recommendations from this particular study, we are now using digital tools to try to manage. So we are using digital tools Sorry, I think my train of thought got a bit twisted there. So we're using digital tools to try and manage, to look at COVID-19 and TB. And what we're doing is we're doing bidirectional COVID-19 TB screening. So we have a screening tool that we're using to screen the motorcycle riders. And then, of course, based from the screening component, we then move it to testing, and then we move it to contact tracing, of course, through the county government, and then, of course, linkage to care. And the study aims at, of course, we are building on existing tools, and it aims we introduced an integrated screening algorithm for COVID-19 and TB, and we are also hoping to have this on a remote dashboard for monitoring. That's still underway, it's not complete, but some of the data is already up there. And hopefully, if this works well, then there'll be an opportunity to scale up the model for future use if it's found useful. Next slide, please. So the third recommendation was, of course, using digital tools to strengthen contact tracing, of course, taking into account socioeconomic barriers. And of course, the challenges we saw during this study was that there was very low levels of contact tracing. Both counties, of course, showed very low levels, 19% for Mombasa, 57% for Machakos, within 14 days of being identified as a contact. Those were followed up. It was very poor showing. And of course, interviews with healthcare workers in both counties actually highlighted one of the challenges being insufficient HR and also financial resources, because even if we had the healthcare workers and they're supposed to follow up these contacts, sometimes the facilitation was not available. And one of the things we also noticed was that there was high positivity rates among the registered contacts who are actually tested. So it would have been very helpful if it was possible to actually trace all these contacts. And so, of course, recommendations that we are recommending increased county level uptake of existing digital technologies to support contact follow-up, and also adopting a consultative approach to design contact tracing approaches, which of course would ensure that technologies are used for messaging and also responsive. This would be responsive to social and economic factors that may discourage, contact investigation. If we have opportunities of maybe people, doing self-reporting and also the health, maybe using community health workers to assist in this if they're well facilitated, that would actually push this, in the right direction. Next slide. Yes, I think, so maybe this is where Onesmus comes in, because Onesmus then can give us the position of the ministry.
I don't know whether I need to come in at this point. Through the chair, Jack, you want me to come in now?
I think, are you finished on your bit of the presentation, Jane? Is this where we hand over to Onesmus?
Yes.
You're finished, great. Okay, perfect. So I think, yes, thank you very much. Great insights. And by the way, Jane, if there is I don't know, is there a fuller version of your analysis that there's a web link you can share in the chat, or for others who are watching?
Yes, there's a complete report. I can share the document. It's a PDF. It may not be a web link, but I can share the whole report.
I'm sure people would find that useful. If there is an online version, do send it, or I'm sure otherwise we can circulate afterwards. But and we'll certainly come back to some very interesting recommendations you made there. But please, Onesmus, it would be great to hear your perspective from the Ministry of Health.
Thank you, Jane, and thank you, Jack. Listen, I think the last discussion that Jane touched on, I think everything revolves around what the government is doing and how it has been able to take up some of the recommendations and the gaps that have been identified within that study. First and foremost, we would like to say that if you look at the first part of the interoperability framework, the Ministry of Health through my office, we have been able to come up with a interoperability layer that we are almost finalizing to make sure that we can be able to harness all these systems and be able to create that level of data exchange between the systems. So as a government, we have been able to identify that as a gap, and what we're trying to do is to finalize the document so that it can be able to operationalize the same within the next financial year, maybe from January or maybe from June next year, so that it can be able to have that hardship between the systems. We have also been able to come up with a data center, an integrated data center within the government. It's a kind of a crowd within the Ministry of Health so that it can be able to, as a repository for our systems. One of the major gaps that we have within our system is that one, you see that most of our systems are domiciled outside the government, and that has been a gap that has been identified. And what we are trying to do is to make sure that by coming up with an integrated data center, which is kind of an Afia crown, we are calling it the Afia crown, then we are able to put our resources in one repository. We are also able to facilitate data exchange, and also be able to increase the level of security of our data, so that when we engage with our partners, when we are working with our partners, and even as we implement the other systems, then we are able to implement some level of security that is able to support us as a government. And I think that's also a win-win situation between ourselves and our stakeholders. The other side about the e-health bill, I would like to say that one of the areas that we emphasized on that it's important for us to come up with a enabling legal framework that will be able to enable us to engage and also to invest in digital products. What we did is that we came up with a team to be able to come up with this bill. If you look at our Health Act 2017, see that in section 103, 104, and 105, it calls for us to as a Minister of Health, through the delegated registration, to come up with e-Health Act. What we did is that if you look at the first part of 103, first of all, we recognize e-health as a mode of service delivery. Then after that, to talk about creating a patient-centered system that is able to serve the needs of the patient. And lastly, we talked about the registration. What we have done is that we have been able to operationalize the same. The PS was able to appoint the task force. We have been able to work through our stakeholders. Through the same task force, we were able to identify the various thematic areas that needs to be covered within the bill. We actually identified about 6 or 7 areas. And what we have done so far is that we have been able to work through the virtual engagement. And as we are talking right now, the bill has been finalized. And now awaits the next level of engagement, which is just a kind of a sensitization through the county system. Then after that, we'll be able now to present it to Parliament before maybe the end of the year, so that we can be able to have a legal framework that can be able to govern how we engage with ourselves, with our stakeholders, and also making sure that the government can be able to take control of the investment in terms of digital investment. We also have the architecture blueprint, that is the Kenya Health Sector architectural blueprint. That is a blueprint that guides how various stakeholders will engage with us in terms of investing in the digital product. And the architectural document is ready. It has been released so that we can be able to harmonize our resources to be able to bring our partners together. And I think that has been able to help us in terms of pooling the resources that are being managed by the various partners. We have also been able to come up with an end-to-end solution with something we're calling the Digital Health Platform. Digital Health Platform is an end-to-end solution that we want to implement from the county level all the way to the national systems, the national facilities, so that we have one standardized solution that is able to bring together all the various actors. Because one of the areas that we noted to be a bigger gap in our system is information silos. So many digital systems, all not communicating with each other, each pulling from its own end, but they don't have the area of convergence. So what we see, even if create this integrated environment, and that is calling the integrated data center, we also try to see how we can be able to maybe give one standardized solution to our partners. And working with the NHIF, we have also been able to review the NHIF Act so that even when you talk about supporting the implementation of the UHC through digital technology, then that is founded within the Act. Because right now, as you're talking, when you talk about the UHC, we don't have any provision within the Constitution that touches on the UHC. What we have is Article 43 that touches on access to care, or rather to health for every Kenyan, but we don't have something that can be able to really tie the government to be able to allocate resources. Because when you don't have something that is tied to the law, then there'll be no resource. There's resource envelope not to recognize rather than recognize that area. So we have tried to make this easier so that we can be able to come up with a clear engagement strategy with our stakeholders. We are also coming up with a telemedicine framework. Telemedicine is an area that is gaining traction, and I think if you look at the COVID situation, it has brought us to a level that we need to make sure that any technology that can be used, you can actually be able to make use of it. And that's we have done. And I think if I look at what has been done so far, we are working with between Kenyatta National Hospital and 2 facilities within the county, so that is Hero County, so that you can be able to see how that can be used. So meaning that through the COVID, some other digital tools which have previously not being used have actually found their way into the practice, and I think that's a very positive step for us. We have been talking about how the ministry can be able to digitize even things like the disease response. And I think some of the tools that my colleague Jane has talked about have actually made work easier. And I think people have realized that by engaging, or rather by adopting appropriate technologies, then it is easier for you to solve some of the basic problems that can actually be addressed than necessarily having to invest so much that actually have a cost saving. And also in terms of convenience, it has really been able to improve the access and affordability of care by our clients. That's what we have done so far. We have done so many other things, but I think those are some of the areas I wanted to highlight so that I can also, talk about what they've been able to do from the same study. Thank you.
Thank you very much, Onesmus. Very, very helpful. So let me now turn it to our final speaker, Rigveda, to give some perspective from FIND on experiences here and around the world.
Thanks, Andrew. Over the next 3 slides, I'll just try and quickly summarize the work we've been doing in partnership with country governments and in-country partners on generating evidence and also sharing best practices across countries on how they are using digital tools to strengthen their COVID test, trace, and isolate response. This work is being done under our role as one of the co-conveners of the ACT Accelerated Diagnostics Pillar along with the Global Fund. Our work so far has focused on developing case studies and then also working with country partners to generate evidence in the construct of operational research studies. Back in 2020, we worked with government partners in India, Nigeria, and Rwanda to document how they were leveraging their existing infrastructure, combining it with innovative crowdsourced or citizen-sourced digital tools for COVID-19 management, and sort of documenting these experiences to answer questions from, that we were getting from partners and in-country ministries of health around how could digital tools be leveraged to rapidly collect diagnostic data, use it to inform ongoing activities. You can also find a link to these case studies if you want to go through those later on your screen here. In the India case study, which we'll talk about a bit later, the focus was how a volunteer force of software engineers worked together with the Ministry of Health to put together digital tools for contact tracing, as well as use historical data on testing and from the contact tracing tools to predict outbreaks. In Nigeria, the government leveraged its existing infrastructure and tools, namely SORMAS, to aggregate data and again inform COVID response. In Rwanda, the government used digital tools to link testing as well as vaccination data across public and private sector to patient IDs to first enable patients and the general population themselves to access their testing results, and then of course to also inform their own pandemic response. This, as I mentioned, was right at the at the end of last year, and in this year and going forward, what we are now doing is sort of building off of the experiences that the community has shared and sort of articulated. We are now working across 4 countries and with in-country partners on demonstrating the feasibility and the effectiveness of how digital tools can be combined with point-of-care diagnostics, so rapid diagnostic tests, and then eventually wherever they would be available and approved self-test to enable decentralized access to testing. In South Africa, we are working with Wits University and Essentia, and where the focus is how existing tools such as WhatsApp as well as digital screening algorithms can be used to expand access to testing in non-traditional but definitely very critical settings such as taxi ranks. The focus of the study there is around screening and testing and linking to care for commuters and drivers in a couple of taxi ranks in Johannesburg. I will not speak as much to Kenya because you of course have already heard a lot about the great work that's already happening outside of the collaboration with FIND and also the work that we are doing together with the partners there. In Rwanda, we are working with the Rwanda Biomedical Center, where the focus is on, again, how community health workers can be empowered to go into the communities and use rapid diagnostic tests and also sort of couple it with digital tools for data collection, use, and analysis, so that the government, the Ministry of Health has a good understanding of what's happening in a near real-time basis. And our fourth study is with our partner, the Uganda National Health Laboratory System, UNHLS, where the focus is more on primary health centers, and how, again, digital tools can be combined with the use of rapid diagnostic tests to not only collect patient data, but also understand how the performance, the on-the-field performance of these tests is happening against reference standards that can then be used to inform testing strategies. Can we move to the next slide? Another key point that has, that maybe sometimes gets lost in so much talk about digital tools and like all the digital tools that are out there, is that it's one component. It's really an enabling contributing factor to really make finally data available for public health response. And while digital tools are more a supporting factor across case management activities, across the care cascade, really their true power and their true contribution can only be realized when it is combined with analytics, with the use of this diagnostic data to generate insights as well as prepare and inform ongoing responses. The table that you see here is contains questions that have come up repeatedly in discussions that need to be answered if effective and targeted COVID-19 response has to be implemented. So, for instance, if you look at how digital tools can be used across the entire cascade of patients, providers, process, and product, they can enable data use and analysis across screening and testing. For patients, for example, what we working in South Africa as well as in other countries was that the digital tools have been used to understand what were the specific symptoms or risk factors that were driving the distribution. And for instance, more recently, hypertension and diabetes is also something that's being explored as one of the risk factors for COVID-19. For testing, again, digital tools can enable insight into what is the positivity rate in the population, and if there are vulnerable population segments out there that need to be prioritized for any public health intervention, be it vaccination or increased testing coverage. For providers, digital tools have been used to screen and link patients to care at the provider level, and to also provide at a national level. What are the different volumes? What is really the caseload at a provider level, at a facility level that is being experienced, so that appropriate infrastructural support can be provided at the provider level as well. At a process level, digital tools can have again been used at a screening for screening to understand and map out and stratify do risk stratification for individuals and to prioritize them for testing, as well as to understand what's happening vis-a-vis the overall testing service delivery, and understand if, like, for example, at a specific lab, if there is a high demand for tests and that is resulting in a higher turnaround time, is there a way to like balance out the testing capacity with the demand? And finally, at the product level, the digital tools have also been used to understand if the screening algorithms that have been developed, how effective are they in identifying the individuals who are most at risk of disease. Moving on to the next slide, and this is the last slide, to just maybe make some of those examples and some of those questions that we spoke about more concrete. We did want to like pick out specific examples that we have referenced already and are available in the case studies, as well as will be published via the operational research studies. But in India, like I mentioned, the government developed two applications, Arogya Setu and Itihas, where they used contact tracing as well as predictive analytics to map out and stratify individuals according to their symptoms, as well as the sort of geospatial and demographic data to stratify them and understand at what risk they were to develop COVID, and then also predict outbreaks with a greater than 90% accuracy, so that disease control measures could be undertaken. In Rwanda, Uganda, and South Africa, in terms of how digital tools were used to to understand what were the performance indicators and provide supportive supervision in Rwanda. Like I mentioned, the patient ID has been linked to the testing as well as the vaccination linked digital tools, and with the intent of understanding from an end-to-end perspective how the testing services are being delivered. And in Uganda and South Africa, the focus is on understanding again how digital how the loss to follow up or how the turnaround times for testing service delivery is faring vis-a-vis what the government has set as targets. And finally, on how effective is a digital algorithm at identifying individuals most likely to be infected. Digital tools have been used in Nigeria to understand and map out the linkage between the different symptoms and the test positivity rates, which earlier on in the pandemic, when this was not as common knowledge, it quickly informed the government about the asymptomatic nature of COVID in a large segment of the population. Similarly, in India, as I mentioned, the contact tracing tool was coupled with predictive analytics to map out individuals who were at higher risk, and the positivity rate in these individuals was 10 times higher than those identified with general testing strategies. And as I mentioned, also in South Africa, where we are working with Essentia to provide screening and testing services in taxi ranks. Again, the use of digital tools along with analytics provided some really important insights into which patients were at the highest risk category, and and some of the sort of indicators that were commonly believed to be predictors for COVID, how their linkage to actual positivity is now changing. So this is, of course, like, you can, of course, see that there's a lot happening across a number of sites. But I guess I did want to, in the end, call out 2 points here, that all of these successes that you see here have happened because all of these countries, before the pandemic broke out, they had made investments as part of their health infrastructure into making sure that skilled personnel were available, and that also digital infrastructures was already built out to some extent. And it's really the this pandemic preparedness and this investment in that pandemic preparedness in digital tools for screening and testing that really allowed them to leverage this very quickly, because in actually sort of in responding to so many health priorities, there is not often enough time to then actually sit aside and figure out the digital strategy for how you would even go about responding. So that would be, I would say, the last point I would want to make, and what were like some of the cross-cutting success factors. That's it from my end. Back to you, Andrew.
Thanks very much, Rigveda. Very, very helpful. So some really interesting presentations, both the Kenyan experience and then more generally in some other countries. Please do post your questions in the Q&A chat, and I see we've already got a couple, so let me go straight into those. Onesmus, perhaps to you first. Several programs. Sorry, actually, yeah, there's a couple here, but so yeah, several programs have existing ways to manage their respective data. So for interoperability, what's your plan to navigate the complexity of bringing disease programs together, and how to take on the custody, ownership, and exchange of data issues?
Yeah, thank you, Jack. I think, as I said earlier, what we're trying to do is to ensure that, for example, if you look at the nature of the administrative structures in Kenya, we have 47 counties. What we are insisting on is that if a system is running in county X, most of the data should rest within that county. That's the first requirement that we have put in place, so that we try to reduce the movement of data from one region to another. Then in terms of the interoperability, what we're trying to do is to ensure that, one, the system that we are using, whether you are, if you're using system, maybe a system that is supporting HIV, one thing that we have made it clear is that the system must be able to give us, or rather to avail the API, so that if needs for us to do the integration, we can be able to do that. And then using our aggregate system, the DHS2, we are asking people in the system owners to make sure that we can be able to start thinking about the automated indicator reporting as a way of trying to ensure that systems can be able to talk to each other. Then we are also trying to tell our partners that, one, even if you're running this system, your data must also be mapped within the government. And what we're trying to do is that we are building a resource, a repository where people can be able to host their system so that that can be available to the government. What the current situation is that some systems are not able to even give us data. People are doing the programs, but when you ask for the data is not available. It's actually maybe in another country, or maybe the data is in server somewhere. So we are discouraging people from hosting government data. We are insisting that most government data must be hosted within the government. If you look at the Data Protection Act, you're talking about designating some people are data processors, others as data controllers. You cannot have both roles. You're either a processor or a controller. So we are trying to make sure that as much as possible, once we have the interoperability layer working, then people can be able to actually use the same platform to be able to create the harmony between the various systems. With that, you'll be able to make sure that systems be able to communicate with each other and using the government resources as opposed to individual resources, so that you can be able to have that linkage between the various systems and for data to be more secure when it's centrally available for our use. I know many people may want really to keep their data. That has been a practice all over, but I think the motivation to move the motivation to move our way is more appealing than when you have to keep your data, and then when maybe this project is over, just go and you don't even give us anything that you can show that there was a project that was running. So we are having serious discussion with our partners, with the aim of making sure that we also do the mapping of our systems so that people can be able to understand each other. And we are not trying to overregulate people from keeping the data. We're just trying to create an environment where people can be able to engage freely. Then we are going to create a highway where people can be able to plug in and be able to start using this rather than them building their own platform. Thank you.
Thanks very much. And perhaps to Jane, there's a related question from Olukunle talking about this explosion of different digital tools. So is there a mechanism to ensure existing systems are maximized and duplicate systems with overlapping functionalities can be modified to complement these existing systems?
Thank you very much for that question. I think, yes, of course, there's a very good opportunity there. And I think that, again, would have to be through the stewardship of the ministry, because, you know, we have these different systems supported by different partners. Some of them have the same functionalities, and ideally, if the partners work together, then they can actually reduce the level of duplication in these particular systems, and they can actually be able to support a wider range of disease program areas, because they can actually dedicate specific functionalities to specific tools. And if they're all interoperable, then of course, you know, rather than having, you know, maybe 2 tools, you know, maybe 10 tools doing the same thing, we can actually have maybe these 10 tools supporting each other to do a lot more. And I think if that again would be again through the ministry, you know, just making sure that this can happen. But that opportunity exists, and it can actually, you know, bring results tenfold or even more. Yeah.
Okay, thanks very much. Rigveda, do you want to come back at all on those issues of maximizing the capacity for using digital tools in different disease areas and so on?
Maybe just, I guess, one point there. I think what several countries are already doing to enable that is creating a national e-health architecture so that the cross-cutting nature of these digital investments can be brought in from even design perspective. So I think that's already something that at a policy level will help us make sure that this happens.
Okay, thanks. There's a question about the bi-directional screening for TB and COVID. I don't know who might like to handle that. How did the case management follow post-identification of patients with overlapping symptoms? And were there any restrictions on TB sample collection for testing, considering the high virulence of COVID? Rigveda, do you want to come back on that?
Maybe I'll actually pass that on to Jane, because she's the part of the PI team there.
Perfect. Okay, Jane.
Yes, if I got you correctly, you want to know how the case management happens, you know, after the bidirectional screening.
Yes.
Yeah. So basically, yeah. So what happens is So first of all, at the testing sites, I must say that we have taken care of all the necessary COVID-19 protocols and safety measures are in place. And so therefore, if we have a case who is suspect for both COVID-19 and TB, we have lab personnel, we have the group that are handling the COVID sample collection, and then we have a special group that also handling the TB sample collection. And I think everything was put in place to make sure that during sample collection, there is no opportunity to actually expose people unnecessarily to the risks that they shouldn't be exposed to. So I think that bit is being managed by, we have dedicated personnel for collecting COVID samples, and then we also have dedicated personnel for collecting the TB samples. I don't know if that answers you, or if I...
Okay, I get that was Kirtina who asked. By all means, post if you want any more clarification, and no doubt can follow up afterwards. Just flicking through, we've got a few questions here on the chat. One perhaps for Onesmus here, and many thanks for the insights. Regarding universal healthcare, which you highlighted, could you elaborate on how digital health tools can accelerate progress towards UHC, especially considering the broader digital divide?
Thank you very much. I think I spoke earlier about how Kenya, in terms of administrative structures, we have the 7 counties. Often there has been a lot of investment in terms of digital infrastructure. You see that almost every county is investing in a digital infrastructure or kind of a digital solution. Almost every county has one type of a digital solution. If you look at the way we want to implement the UHC, we're talking about increasing the access, affordability, and the quality of care. With this, I see an opportunity whereby in some counties where we don't have enough manpower, but we have access of the same in other counties, we can be able to leverage things like telemedicine. Telemedicine is a basic investment that people can be able to use towards ensuring that people can be able to access care at the primary level. If you look at how telemedicine, the potential of using telemedicine, if you look at the digital penetration within the Kenyan landscape, I think you see that there's so much that can be able to do. That's why we are trying to see how we can be able to leverage on the same to make sure that those people who require care, they can be able to access care. They don't necessarily have to move for far distances. That actually help them to get the care that they are looking for. Talking about the digital divide, yes, I agree with you. Yes, it is a reality, but what we are trying to do is through the digital strategy, we have the e-health strategy, the Kenya e-health policy. We are trying to support or to sensitize counties to be able to come up with county-specific investment plans that try to address some of these gaps that exist as a reality. In this case, I see a lot of resources going to the county, rather the county allocating more resources to support maybe, for example, digital infrastructure, buying maybe the basic requirements like computers and this kind of things. Otherwise, even as we are talking right now, the national government is also still supporting some of the counties to be able to get some level of digital infrastructure that can be used to support the digital investment. But as we talk about the end-to-end digital health platform that we are working on, we are looking at how we can be able to start piloting this in collaboration with the National Health Insurance Fund. So this is some of the good low-hanging fruits that you can be able to ride on as you try to see how you can be able to address this issue of digital divide across the counties. The other question that was addressed about the issues around, there's a question I saw that was open to me. I don't know whether that Jane has addressed that. But by and large, I would like to say that there's one, yes. I think there was one from I think I addressed this one about the issues around interoperability framework. I talked about that. But I think issues around the custody, ownership, or the exchange of the data, this is an area that we have had a discussion with our partners. Because what you're asking, how the PA programs which are existing have ways to manage their respective data. So on the interoperability framework was a plan to include the complexity of bringing disease programs together to agree on a common, rather taking custody ownership. I think this is what I talked about the integrated data strategy. We are really telling them that if you want to engage with us, and I think when you talk about our architecture, the blueprint, we are telling people you have to invest within the provision of architecture. You're not going to come up with a new investment architecture that people want. They may be very enticing for them to use, but we are telling them that you have to work within the government guided infrastructure and also the architecture, so that when you talk about issues around the cluster awareness and access of data, it is within the government framework, so that we don't have these issues of people keeping data which is not which is against the law. If you look at the Data Protection Act, the policy which we came up with in 2016-2030, it is illegal for someone to keep government data without the, without the involvement of the government, relevant government offices who needs to grant you permission. Rather, you need to declare that I'm holding this data, this is how I'm using it. Otherwise, that will actually be running counter to the legal framework that we established with the Data Protection Act 2019.
Okay, thanks very much. A really important point there about the privacy issues around data that we're seeing in so many places. We've only got a few minutes left, so let me quickly just a couple of other questions. So for Jane, please could you expand on some of the reasons why certain digital solutions were deployed but not used at facility level, and any lessons from this for the broader digital health community when we think about designing and implementing tools?
Yes, thank you very much for that question. I think one of the key reasons why some of these tools were not used even after deployment was the issue of capacity. I think training was necessary, and I think this was not available in some places, and also the lack of human resource. Those are the two main reasons why I think you would find that a tool has been deployed, but then they're not able to use it because they have not interacted with it before and they have not gotten training. And also maybe sometimes some tools were also too demanding. So maybe the tool is quite lengthy, and so therefore the health workers find it, it requires so much time. And generally also most of these health workers had a lot of workload. So when they realized that the tool was sort of coming in the way, then they would prefer to perhaps abandon it and come up with a quicker way of doing this. And so maybe as we develop some of these tools, that is something we need to consider. We need to consider making a tool that actually doesn't really bog down the person who wants to use it. But then also when tools are developed, the human resource is supposed to also be trained to be able to use it. Thank you.
Okay, thanks. Just want what Jane have said. I think some of the tools that we saw during that, remember that during the COVID times, there was desperate moments, so they were calling for desperate responses. We see that most of the digital tools did not follow the digital development principles, whereby you need to work with the users. So you find that some people are just coming and dumping solutions, expecting that the people are going to use it. So that's why we see that even some of the counties actually abandoned some of the tools because they were not involved in the initial development of the tools. So really, I would call upon that when we are doing this kind of an assignment, make sure that we work with the users, and the users are very important because they define the success or the failure of the solution. So working with the users, we have been able to see good things coming our way. We've been able to even build the ownership, and that's what has made us move in the direction we have moved. Thank you.
That's very helpful. There's a question here on COVID and malaria co-testing. How did that happen, given the huge overlap between symptoms? Is that something, Jane, you might answer?
Sorry, I didn't get that.
On the overlap between, so how did, what about COVID and malaria co-testing? How did that happen, given the huge overlap between symptoms? I don't know if that's something you can answer.
I think for our study, we are not doing COVID and malaria. We were doing COVID and TB, where there were overlaps, not COVID and malaria.
Yep.
However, I don't know.
Maybe I can attempt to address that. So not in the study that Jane mentioned, but I think it kind of links to what's already in place, because it's if you look at the response time for this, it's not been like multiple years. So for COVID and malaria, in a sense, this is something that's happening via digital tools in, for example, Burkina Faso, via existing tools that were already in use for community level screening for malaria. This project is being undertaken by one of our partners, TERDEZOM, as well as the Ministry of Health in Burkina. But the point is that it's definitely happening, but it's more that it's being layered on to where the malaria intervention was already in place, not so much the other way around. But that's a good point as to like that needs to also be looked at in addition to COVID and TB.
I'm very mindful of people's time. Maybe just a final sentence, perhaps from each of you, which distills a couple of the final questions here. So how to leverage the gains made during COVID with introducing digital apps to other health programs, and what are the key factors that promote rapid deployment of digital tools to respond? Rigveda, do you want to say a couple of words very briefly, please?
Yeah, thanks. So I would say the first one is that looking at what are the existing tools out there and expanding those to make sure that they can become as widely used as possible. And that has efficiencies both for investment as well as for making sure that we are not burdening healthcare workers with like multiple tools for multiple diseases. And then second, what I already mentioned earlier, which is that to actually respond for preparedness, digital health infrastructure investment is key, because there will never be enough time to come up with new tools, train people and deploy them while a pandemic is ongoing. Okay,
Onesmus, a brief word, your key word of advice.
Thank you. I think my advice is that I think the lesson that we learned from the COVID, I think is an eye-opener for us to start thinking through how in future can be able to manage similar issues. For example, I think one gap that we saw is that there are no digital solutions for this kind of pandemics. And that is an eye-opener for us as a country, because we are thinking of how some of the digital tools that we have been able to come up with can actually be supported, facilitated, and sustained, so that in case of any other pandemic, you can actually be able to have a fallback plan, other than when you started, when you have nothing. And I think that's why you can see so many tools coming up, and most of them, they're not even able to serve the purpose. So really, I would really recommend that countries look forward and make sure that they plan ahead, because make sure that they can also have a framework that can be able to adopt in case of such epidemics. Thank you.
Thank you very much. And Jane, a final word, please.
I think maybe just to add on what has been said, we can actually leverage on the successes we've seen. Some of these tools work very well, and we can actually build upon these tools to actually support other diseases. We don't have to again start developing from basics. We can actually build on this. And maybe the other thing that can be done, because you find, like, for example, in countries such as Kenya, these tools are supported by different partners. Maybe partner coordination, I think, through the ministry would also go a long way, so that we use the existing resources, but then now we are able to use them more efficiently, because all the partners are being coordinated. Thank you very much.
Well, thank you very much then to Rigveda, to Jane, and to Onesmus for some really interesting insights. We've heard some fascinating examples of practice, which is great, as we've seen this huge explosion during the pandemic of digital tools, but we've also heard some really important insights about the challenges of interoperability, around consolidation of data, about the need to work with users on the ground, and the challenges really highlighting that digital tools in themselves certainly aren't a solution. They can't be quick fixes to these deeper issues. And the real challenge is how to deploy them at the lowest levels of care with lots of coordination, as we heard. So great insights. You've seen the fuller report that Jane's made available, and no doubt others can follow up with any particular further questions and insights. But thank you all for joining a very interesting and helpful session.
Thanks, Andrew. Thanks, everyone, for joining.
Thank you.
Thank you, everyone, for joining.